Hello, everyone. Welcome to this combined lecture with both Chris and I. We are going to be reviewing some other clinical application type stuff, and then also our final take-home points for the cervical course. So we hope you've enjoyed all the content up until this point, and this is kind of hopefully going to wrap it all together for you all. First of all, our treatment philosophy, and on the first slide above on this page, you'll see the same slide, and that's because this information to us is really the bread and butter or the most important part of our cervical examination and our whole philosophy behind the cervical spine. With that, the first thing I think even more important than the manual therapy techniques or your dry needling skills, for example, is your ability to establish therapeutic alliance. And therapeutic alliance is your relationship with the patient and them having trust in you as a practitioner. Even if you're the best practitioner in the world and they don't trust you or they don't believe what you're saying, these skills won't translate over. So building therapeutic alliance is the first and foremost, most important thing I do with patients. Would you agree with that, Chris?
Yeah, and I think a big part of that is just patient education as well. When we think back to our case regarding whiplash recovery, I think one of the number one things we have to do and what the research has shown is just educating the patient on their condition, on the prognosis, but we also don't want to overly focus on pathoanatomical explanations. Even if we think that it might match a specific way, we should focus on educating the patient on how they can get better with a conservative approach. And if imaging findings come up, we keep it as non-threatening as possible.
Completely. And on that note, when it comes to building therapeutic alliance, that is going to be, the education is key, but then you have to also tailor that to the person. So recently I had someone who had chronic, about 3 years of high persistent low back pain. So at that point we know it's not an anatomical structure. It's more of a central sensitization in the brain. And the person came in and they said, it's not any of that pain science BS. This is a real mechanical problem. So if I lead with that person and say, no, it's in your brain, I'm going to lose that person right away. So
yeah, don't tell them it's in your head.
Yeah, exactly. I mean, and if you listen to the patients, they'll tell you what the answer is. So I think to what Chris and I are both saying is that education is key, and make sure you tailor that education and sometimes be softer with the education for certain people based on the information, the nonverbals that you're getting back. The second point, address mobility restrictions and pain sensitivity through repeated motions, active stretching techniques, manual therapy, and other interventions that you use. That is, at least after I do my evaluation, all the treatment on the initial visits is focused on really the pain sensitivity aspect of the treatment. So let me get their pain down, let me get them moving, and then let's kind of rewire or reprogram how their nervous system is perceiving that area of their body. And that's through all of those things that we have listed. Would you agree with that?
Yeah, and I'd say, it's different for each person in a sense of what they'll have a greater response to. We want to incorporate what the research says, but one of my colleagues recently said if someone comes into your clinic asking for a hamburger, you got to give them at least a bite, just to kind of help build that relationship. And I think that same sort of mindset plays here. Even if the research is saying, exercise is what's going to get someone better for a specific diagnosis, and they are coming in asking for a specific manual treatment, you might want to incorporate it a little bit and then, start with a little education while you're doing that, and then work into things that we know research has a little more value.
Absolutely. And I know you and I both do some iStem treatment.
Mhm.
And I had someone come in the other day and they said, I had Graston on my neck before and it helped so much. And I wasn't going to do it initially, or it wasn't on my mind to do it because I was going to do some dry needling and some CT junction manipulations and so forth. Once they said that, I led with that. I identified their pain. I went with that because they already have a bias towards that intervention. So that's where addressing the pain sensitivity with a strategy that already matches their bias, even if it's placebo based, who cares? Because we're bringing their pain down. Anything else to add on that one?
No, I think you covered that really well. Just kind of wouldn't say like open-minded, but be prepared to kind of pick up any signals a patient's saying on what has helped them before and what they think might help them based on their current condition.
Absolutely. Point number 3 is train movement patterns and support overstressed motions and postures. I That is huge for me, especially when it comes to support those overstressed motions and postures. A lot of times, at least in the current physical therapy world, outpatient orthopedic, there's this huge discussion over a good versus bad posture and whatnot. And for me, a lot of times the quote unquote good posture is a position that is going to give that person relief. So that's why I usually start in that window, because they're doing these things over and over again that are stressing their body. Let's say that's even something as simple as answering the phone and turning their neck to the side over and over again. So if they're always stressing that motion, well, we can either do something to support it so we can make that easier, or we need to train the movement pattern to be able to accomplish that, and then also work the opposite patterns to make sure that they're staying relatively symmetrical. What would you
Yeah,
say?
I think that this point specifically is related to our lectures on Sowerman's movement impairment syndromes. And after going through the lectures, it should be pretty clear how biomechanically based that thought process is. And I think that what we've been trying to present, and I'm sure you can kind of tell, is this happy medium of pulling in some of the pain science side and what the
Mhm.
research is showing in regards to non-pathoanatomical findings, but at the same time incorporating what biomechanical aspects do play a role. And when a patient presents with certain aggravating and alleviating sort of patterns and postures, we'd be fools to not try and address that to bring down that sensitivity. So
Mhm.
if it's, adjusting their armrest height so that the upper trap's not applying quite as much compression while they're sitting at their desk, that maybe that's something that we do. If they're, like you said, on their phone and they're moving in an abnormal way and we have to address that, let's do it. But I think by addressing those regular, what we call repetitive motions and prolonged postures, we're going to at least address some of the sensitivity that's occurring throughout the day.
Mhm. My final point that you reminded me of is the addressing the pain sensitivity, like I said earlier, is very important for me. And if the person comes in high levels of pain, sometimes repeated motions, from what I found, is not the option that day, because they're almost too guarded, too fearful. Even
Absolutely.
though if I feel like it's the right technique, again, that goes back to the therapeutic alliance part. If I'm having this person push through an acute pain that's actually just raising their fear and their alarm, then it's not going to be as successful of day one. Maybe I just do some easy, more good posture type things to
Mhm.
make them feel comfortable.
Exactly.
I was actually talking with Dana too, the owner of Optum. We both know him pretty well, and he was saying that we PTs are much better at treating more kind of chronic problems, but like when that person comes in with an acute issue, that's where I think we struggle, because we always try to go to this pain science approach right away. And I mean, yes, we know that manual therapy has questionable results in the long term for things. But gosh, I mean, sometimes if I hurt something, like it feels pretty damn good to massage it or manipulate it. So I mean,
Mhm.
there's something to that, as long as it's backed up with all the other steps.
Exactly.
Okay, finally, strengthen weak muscles and progressively challenge load. That ties it all together for me, because the graded exposure, or the gradual challenging of more of harder stimuli, is really what I go for. So maybe on day one it's more of a neutral posture type of position, but then day two, let's say the person has a job where they have to look forward into a forward head posture position. Eventually, I'm definitely going to be training those harder movement patterns that would fall outside your kind of normal good posture or good mechanics thought process.
Yeah, I think that the the biggest thing that probably changed my practice patterns, several years ago out of these points was the progressively challenging the patient's load. And it's so easy to just have your patients go through the same, 3 sets of 10 or whatever. I think that's what we hear the most. But all of a sudden, if you start trying to really fatigue out your patient, whether it's endurance based or strength based training or power training, um, you see the exercises accomplishing what they're designed for, as opposed to just looking to get stronger, even though you're not loading it properly. That being said, you have to know how to regress a case too. So if a patient is really acute, you're not going to be trying to hit them with a hard, like 3 sets of 8, maxing them out. It's more so that we're going to, just try and, again, it goes back to address the pain sensitivity and build them up so that they can do more.
The education I give on that point is, and this is kind of like to save face for myself maybe or something, but it's I said, well, that is the right movement and we're going to get there eventually, even though it flared you up unfortunately initially. We're going to take we're going to take a regression of that movement, and then we'll gradually get back to that. So because
I think it's a great way to handle it.
I've overloaded somebody on too early because I thought they could handle the pain sensitivity aspect of it.
Mm-hmm.
I've definitely gotten bit for that.
Oh yeah, that happens to all of us.
The final point on there is be sure to regularly reassess your asterisk sign to make sure your treatment is as efficient and specific as possible. I start every visit with a reassessment of some sort. I want to see what their problem was on the initial evaluation, and then I want to retest that same problem in the same, as close to that similar environment as possible.
Yeah, I think that one, it kind of tells you, are you making overall progress? And then two, what sort of retention the gains are having. And then it also can tell you, is the patient keeping up with their home program? Or is the home program not appropriate at this time that needs to be addressed?
Absolutely. So that's our treatment philosophy. There is so much information here, and we can take each one of those points different directions. But this really is the bread and butter of my entire practice. Next slide, some general points on clinical application. Again, build therapeutic alliance. We can't stress that enough. Must check the regional joints and areas of the body around the cervical spine. So for me, that's thoracic spine, CT junction, shoulder, really anything that's kind of, above the TL junction is what I'm looking at, and sometimes lower if I think it's important.
Yeah, I think that's a really good point. You want to be efficient. So I think our standard exams, we always include cervical spine, CT junction, thoracic spine, shoulder mobility. But depending on the patient's function, depending on their level of activity, that might expand a little bit. If it's a baseball a pitcher, we might also start looking a little bit closer at the elbow mobility. Maybe even something down at the hip rotation. You have to think about their whole body regular tasks and where those restrictions may be, in order to identify when you may need to spread out your exam a little bit more.
Absolutely. Point number 3 is all about safety, and I think that kind of goes without saying for me. That's not a question at all. It's, I'm always doing those safety tests to make sure that the person's appropriate for care, and then even session by session, I'll reassess a transverse or alar ligament just to make sure before I do a manipulation that it's safe. And if nothing else, I'm getting great repetitions at practicing those.
Yeah, it's so quick and so easy to do that to me it's like it's part of my application in my hands. Like, all right, let me just check the transverse ligament, the alar ligament, possible Jefferson fracture, and then all right, now I can get a little more serious about whatever I was going to do.
Mm-hmm. Finally, treat your impairments. I know there's been cases, especially more difficult acute cases, where there's definitely some biomechanical stuff that needs to be worked on, where I've thought like, wow, there's a lot of different moving parts going. Where do I start? And for me, it always comes back to identifying the primary impairments, my 1, 2, and 3. I knock those out first, and I kind of reassess where I'm at. So when in doubt, treat the impairments.
Yeah, I think that's just a good guideline, in that if you are feeling lost at all, if you've been thorough with your exam, you're going to identify the impairments, and some of them are going to stand out a little bit more to you. Some of them will almost coexist, and if you don't address both, you're not going to see the changes. But that's a great starting point, and address what you can. There's going to be more there than you probably are able to handle, especially with how far gone some deficits and impairments are. But do what you can.
Yes. And my final point on that would be, if you have 10 impairments, don't try to do all 10 on the first visit. I would say take 1 or 2 and work through those fully, and make sure you're not overdoing it, of course, it's aggravating their symptoms. But identify those first few, and then likely 4 through 10 are just going to fall out because when your top ones get taken care of, everything else kind of falls into place. Hey, what do we have next here? Treat the impairments. And this is, Chris, would you want to start this one off? Because like, I know this kind of goes back to more like the SARM and stuff that we talk about in that lecture.
Yeah, this is a concept that I remember in my residency. It was presented by my mentor that really kind of simplified what PT is to us. And what that is like, what is it we can do as PTs? If a muscle is tight, we stretch it. If a muscle is weak, we strengthen it. If a joint is stiff, we move it. If we see an abnormal movement pattern, we try and correct it. In reality, like when it comes to our impairments, we want to try and address those specific things. Yeah, there's a couple other little things out there, like, obviously education isn't talked about much here, but when we're speaking specifically about impairments, I think this is a great starting point to really simplify things, especially if you're feeling lost.
I would love to hear your perspective and thoughts for the lecture on this. In general, I will always kind of treat the stiffnesses and things first, and then I'll do more of the therapeutic exercise, neuromuscular stuff as a secondary. I
I'm
know
kind of in the same mindset. Like I always start mobility myself. Well, I shouldn't say always. Most of the time I do. If there's someone that is really, really weak, obviously I'm going to focus much more on strengthening. But
and
it's
likely that
almost always
person
they're
is
coupled.
hypermobile almost everywhere.
Yeah, exactly. But almost always they're coupled together. Like it doesn't make sense to stretch a tight muscle and not try and reinforce it the other way because it's just going to fall back into that same pattern.
Yeah, absolutely.
Yeah.
I had one more point on that, but I mean, we did a pretty nice job covering it. Anything else you want to add there?
No, I think that covers it. Other than, again, that's a starting point, and we can't forget, to address the biopsychosocial factors, building the therapeutic alliance, do what the research says, consider your patient's preferences in your treatment. Like this is just a good starting point to really bring it down to a foundational level.
Mm-hmm. Absolutely. Okay. As we talked about earlier with the idea of stress, like looking at all the regional joints, it's really important that as a practitioner, that you're not missing simple things because you're not screening for them. So the concept of regional interdependence, which is that even though pain is in one area, it can be coming from a different region of the body, kind of the body is all connected idea. That's been with us for a while. And I think where we're at, where the whole physical therapy community is at, it's kind of unacceptable if you're only looking at the joint of where the pain is at.
Yeah, I think that the big thing here in my mind is the more thorough you are with your exam, the more likely you are to pick up those impairments that we want to address. And that's kind of where it comes back to trying to make it as systematic as possible too. And that's where, like when Jim and I presented the exam portion of the upper quarter screen, if we do the same thing over and over again with our examination, we're going to pick up on everything. Yeah, there are a few things that we're going to leave out sometimes and add in other times, depending on the case. But if we do those primary aspects every single time, we're going to pick up on almost every impairment that we may need to consider down the road.
Yes. The last thing I want to talk about here is the biopsychosocial factors. I pretty much, like, if you know you're working in a high persistent pain population, then maybe you kind of go there first. I'm in a fairly affluent area, so I always keep those in mind, and I bring those up as additional factors. I often explain it as we have our kind of core, more biomechanical things on our inner circle, but then other things that impact that would be more of your biopsychosocial. So stress and sleep, they're going to impact what your posture is like, how you're holding certain muscles. They're going to impact the sensitivity of your nervous system. So it's like I'm addressing those in maybe indirect ways. I'm bringing in education about it. I'm making sure that they're sleeping well, for example, but I'm not focusing directly on that unless something's really jumping out to me.
Yeah, I think you kind of like work those in simultaneously. Like while you're having a patient exercise, maybe you're asking about some of those concepts, or maybe you're educating simultaneously. I can't say I do a ton of like just sit there and educate. I'm not going to lecture
Yeah.
to the patient, but I want to retest them and make sure that they are retaining and understanding what we're talking about.
And this shouldn't be rocket science, because if you're actually like looking at the patient and talking to them, like you have a good idea of what their life is like. I
Hmm.
had someone post knee surgery the other day who eyes were bloodshot. Like I could tell this woman she was exhausted, and it didn't look like she was eating very well. So I focused more time and attention on those components. Yeah, as I was asking about it, very stressed, not hardly sleeping at all right now. And I politely said, "How do you think your body is healing if you're never recovering? It's like you're constantly going, constantly sympathetic. You need to give yourself some parasympathetic drive." Any final thoughts on this?
No, I think you covered it well.
Okay, last slide. We wanted to include this because dry needling is becoming more and more a part of of a lot of people's practices, and the research is still mixed. So we thought that it was important to cover it here as part of the clinical overview, but then also we have a separate lecture on it.
Yeah, I think some of there are different schools of thought as to how dry needling is applied. And there's still, confusion as far as the research goes, because a lot of what people use as research is acupuncture, and and dry needling are not necessarily the same thing. And, when the dry needling course that I took, it kind of started off with the Trevelyan-Simmons trigger point referral patterns, but it goes beyond that. If you have pain along the track of an L5 dermatome, you're going to want to try and not only dry needle the lumbar multifidi in that area of L5, but you're probably going to also want to follow the path of the nerve and dry needle those muscles as well. You may want to consider dry needling specific impairments. If someone has restricted gastric length, maybe you want to dry needle to try and loosen that up. Maybe you're looking to do it to just address motor patterns. There are a lot more applications to it than simply just, this matches the Trevelyan-Simmons upper trap referral pattern.
Mm-hmm.
You want to make it as dynamic as possible.
Absolutely. And I almost always, or I hardly ever do not pair the kind of origin of that in the nerve root area of a muscle as I'm simultaneously doing the muscle itself. So
Mm-hmm.
if it's the bicep that I'm working on, I'll most likely needle around the C5, C6 paraspinals and multifidi, simply because I want to make that neural connection from start to finish as smooth as possible. And then also, as the point says at the very bottom in the white box, that even providing a novel stimulus, and it's a pretty potent stimulus sometimes, like the patient really feels it, that can be enough to rewire, and I'm saying that in air quotes, the nervous system, or give them different input so they can then change the movement pattern, which can make them feel better.
Yeah, I think that even though the research is still kind of lacking, the biggest indicator for us too is, do our test retest, use that asterisk sign and see what kind of changes we are able to get with just, a simple dry needling session or whatever it is that we're implementing. But, make it as multimodal as possible.
Mm-hmm. If anyone has questions on this lecture specifically, feel free to send us a message, because this is what I enjoy talking about the most, frankly.
Mm-hmm.
It's the process and how to tailor that process to each individual person. That's kind of what gets me excited about every evaluation.
Yeah, this is like where the real clinical reasoning comes in for treatment, while incorporating all that other stuff we talked
Mm-hmm.
about with different methods of treatment, different methods of examination, the biopsychosocial factors, everything. So this is what ties it all in my opinion.
Yeah, absolutely. Well, thank you again for joining us on this lecture, and we hope that you continue to follow the rest of our stuff. Thank you.
Thank you.